So today's topic of the class is obstetrical hemorrhage, and we'll be discussing the same. Though I have previously covered the topic of postpartum hemorrhage and antepartum hemorrhage, but still this is an overall review of what happens in obstetric hemorrhage, and it includes these topics as well. So what is basically major obstetrical hemorrhage? It is any kind of excessive bleeding during pregnancy or related to pregnancy in a parturiente. This could be during pregnancy, childbirth, or in postpartum period. Bleeding typically occurs vaginally, but rarely it could be in the abdominal cavity. Available evidences suggest that severe hemorrhage is the most frequent cause of maternal mortality and morbidity all over the world. There is no universal consensus on the exact definition of massive obstetric hemorrhage. However, in most of the institutions, it is defined as a blood loss of more than 1500 ml or a fall in hemoglobin of more than 4 gram per deciliter after acute blood loss in a parturiente or need for blood transfusion of 4 or more units of blood in a parturiente patient. Then definition based on hemodynamic values are not very useful for diagnosing it, as the physiological changes associated with pregnancy sometimes mask the clinical presentation of hypovolemia that leads to delay in recognition of blood loss and initiation of treatment. Now, what are the main causes of the obstetrical hemorrhage? In antepartum period, the causes include placenta previa, placental abruption, coagulopathies, uterine rupture. During pregnancy, it includes laceration during vaginal delivery. In postpartum period, primary postpartum hemorrhage that occurs within 24 hours of pregnancy mostly is because of placenta accreta, placenta increta, or placenta percreta. Secondary hemorrhage that occurs after 24 hours to 6 weeks after delivery mostly is because of retained products of placenta. Then local causes can also lead to bleeding anytime during pregnancy. That could be because of cervical lesions, dysplasia, cervicitis, polyps, ectropion, carcinoma, and following sexual intercourse, and clinical examination, following clinical examination. What are the complications of this antepartum hemorrhage? Fetal complications usually are hypoxemia, premature delivery, growth retardation, intrauterine death, congenital malformations, birth asphyxia. Maternal complications, the severity of it depends on pre-existing anemia and the amount of blood loss. Acute hemorrhagic shock and its sequelae could be there. Acute kidney injury can occur, which may result in renal tubular necrosis. Premature labor may set in. Postpartum hemorrhage are more frequent in patients who had a history of antepartum hemorrhage. Then retained placenta in case the placental anomalies are present. Complications which are associated with massive blood transfusion could occur. Coagulopathy, transfusion-related acute lung injury, and they are associated with higher cesarean section rates. Peripartum hysterectomy, puerperal infections, maternal deaths. What are the percentage of maternal deaths associated with obstetrical hemorrhage? Abruptio placentae 19%, uterine rupture 16%, uterine atony 15%, coagulation disorder 14%, placenta previa 7%, placenta accreta 6%, and retained placenta 4%. So majority of the causes include that postpartum hemorrhage and the antepartum hemorrhage that includes the cause of abruptio. And inadequate resources and personnel, for example, home delivery attempts, failure to prepare for obstetric hemorrhage, example, no IV line started on the admission, then delay in recognition of hemorrhage, delay in treatment of hemorrhage, and treatment failures are few of the causes that lead to maternal mortality in case of hemorrhage. What includes the antepartum hemorrhage, that is during pregnancy? The abruptio placentae, placenta previa, uterine rupture. Definitive treatment of these are cesarean section, and simultaneous preparation for transfusion should occur as needed. If heavy bleeding continues after the cesarean section, then treatment is as of postpartum hemorrhage. Then postpartum hemorrhage. Etiology, bleeding from the placental implantation site. The linked factors are hypotonic myometrium or uterine atony, some general anesthetics which are used sometimes, then poorly perfused myometrium, over-distended uterus, prolonged labor, very rapid labor, oxytocin-induced or augmented labor, high parity, uterine atony in previous pregnancy also, PPH if had occurred may lead to recurrence of PPH in this pregnancy. Then chorioamnionitis, retained placental tissue, avulsed cotyledon, succensurate lobe, abnormally adherent accreta, increta, percreta, all these results into postpartum hemorrhage. Then trauma to the genital tract. It may be because of large episiotomy, including extensions, lacerations of perineum, vagina or cervix or ruptured uterus. And coagulation defense intensify all the above risk factors. Then what are the clinical features of shock? There could be, in early cases, there could be altered mental status, tachycardia, orthostatic hypotension, oligouria, tachypnea. There may not be any change in the hepatic or gastrointestinal function. Hematologically, you may find anemia, and metabolically there might be nothing. But in late shock, the mental status is obtunded, the cardiac failure may ensure, then arrhythmias may occur, hypotension is there, anuria could occur, tachypnea, respiratory failure, liver failure, mucosal bleeding, coagulopathy, and at last metabolic dysfunction like acidosis, hypocalcemia, hypomagnesemia, all these could occur in late shock. What is the categorization of acute hemorrhage? It is classified into 4 classes according to the percentage of volume that is lost. Class 1 includes 15% loss of blood. Class 2 includes 15 to 30% loss of blood. Class 3 includes 30 to 40% loss of blood. And Class 4 includes more than 40% loss of blood. In Class 1, the pulse rate remains less than 100. In Class 2, it may increase more than 100. In Class 3, it further increases to more than 120. And in Class 4, it increases to more than 140, almost threading. Pulse pressure is decreased in all the classes except for Class 1. And blood pressure is also decreased in all the classes except for Class 1, where it could be normal or compensatory increased blood pressure might be there. What is the goal of therapy for obstetrical hemorrhage? We have to maintain the systolic blood pressure to more than 90 mmHg, urine output to more than 0.5 ml per kg per hour, and the normal mental status. We have to eliminate the source of hemorrhage, and we have to avoid overzealous volume replacement that may contribute to pulmonary edema and may be further harmful for the patient. The management protocol include management of hypovolemic shock, other than also examining the uterus to rule out atony, examining vagina and cervix to rule out lacerations and repair if present, exploring the uterus and performing curettage to rule out any retained placenta. For uterine atony, we have to give bimanual compression, oxytocin infusion of 40 units in 1 liter of D5 or RL. Then 15-methyl prostaglandin, that is prostaglandin F2 alpha, 0.25 to 0.5 milligram intramuscularly. It may be repeated every 15 minutes and a maximum of 8 doses can be given. Methergine 0.2 milligram IM or prostaglandin E1 200 microgram can be given. Then or prostaglandin E2 20 milligram are second line drugs in appropriate patients. These are, we all know that prostaglandin mesoprost that can be given up to 8,000 microgram. Then bilateral uterine and surgical options, we have bilateral uterine artery ligation, bilateral hypogastric artery ligation if the patient is clinically stable and future childbearing is of great importance, and hysterectomy is at last, the hysterectomy is the last resort. In case of hypovolemic shock, what we have to do, we have to insert at least 2 large catheters, IV lines, start saline infusion, apply compression cuff to infusion pack, then monitor the central venous pressure and arterial pressure. We have to alert the blood bank, take samples for transfusion and coagulation screening. We have to order at least 6 units of RBCs, packed RBCs. Do not insist on cross-matching the blood if transfusion is urgently needed. Then the patient has to be kept in Trendelenburg position, that is the leg up position. Warm the resuscitation fluid because hypothermia may further this may increase the shock. Then call for extra staff, including consultant anesthesiologists and obstetrician, and rapid infusion of 5% dextrose and ringer lactate while blood products are obtained. And transfusion of red blood cells as possible. Until then, if not available, crystalloid maximum of 2 liters can be given, or colloid maximum of 1.5 liters. Restore the normovolemia, which is the priority. Monitor red cell replacement with hematocrit or hemoglobin using coagulation screen to guide and monitor the use of blood components. That should be in the replacement of 1:1:1. And if massive bleeding continues, FFP 1 unit, cryoprecipitate 10 units has to be given while awaiting for coagulation results. Monitor pulse pressure, pulse rate, blood pressure, central venous pressure, blood gases, that is RT-ABG, and acid-base status, urinary output, because and we have to monitor urinary output by catheterization of bladder and considering adding oxygen by mask. This has to be done. And what orders has to be given? The orders of transfusing 2 units of packed RBC immediately, using cross-match if available. Otherwise, type-specific or O-negative blood group can be given. Call the blood bank with the patient's name, medical records, and to request for 2 units, bring a request for release of blood. These things that we all do during emergency has to be done. Then this I already told, the causes of maternal mortality by different causes of hemorrhage. Now, postpartum hemorrhage traditionally is defined as loss of 500 ml of blood or more after completion of 3rd stage of labor, which is based on clinician's estimation of blood loss. Problem with this is that almost 50% of deliveries lose more than 500 ml of blood. Estimated blood loss is often less than the half the actual blood loss because visual estimation is not that accurate. And most of the serious causes of postpartum hemorrhage have origins prior to the end of 3rd stage of labor. Postpartum hemorrhage, as defined, is technically misdiagnosed and clinically irrelevant. And so this term, postpartum hemorrhage, should be replaced with the term obstetrical hemorrhage. Then the other causes of obstetrical hemorrhage include the placental cause, which includes placenta previa, abruptio placentae, with a placenta accreta, increta, percreta, and vasa previa. Obstetrical trauma, uterine rupture, lacerations, operative traumas like cesarean sections, episiotomies, forceps, vacuums, rotations. Uterine atony may be because of retained placental tissue, over-distended uterus, inhalational anesthetic drugs, uterine muscle failure, or grand multiparity. Coagulation defects that is contributory to all the previous causes may be sepsis, amniotic fluid embolism, abruptio placentae associated with coagulopathy, then HELP syndrome that is associated with severe preeclampsia, dilutional coagulopathy because of overzealous use of the fluids or blood, then inherited clotting disorders, anticoagulant therapy. All this results into obstetrical hemorrhage. Few words about abruptio placentae. It occurs in 1 in 200 deliveries. There occurs painful tetanic uterus. Bleeding may be hidden initially and causes 12 to 15% of all stillbirths. It cannot be predicted by tests for fetal well-being like NST or not BPP. It can be associated with preterm labor, and the causes risk factors include previous abruptio that may recur in 10% of cases, elevated blood pressure that could be chronic or preeclamptic that results in 1% of cause, Preterm premature rupture of membranes may result because of 1 to 2%. Cigarette smoking is associated with 1%. Cocaine abuse is associated with 15%. And blunt abdominal trauma is associated with 1% of cases of abruptio placentae. Diagnosis may be less important than the clinical presentation, and treat the bleeding and fetal distress with delivery, and often we have to do cesarean section. Treat the maternal blood loss and disseminated intravascular coagulation with IV fluids and blood products. Then placenta previa, it occurs in about 0.5% of pregnancies, like abruptio placentae, painless. Antepartum vaginal bleeding is there. It is best diagnosed by ultrasound, delivery at term, or when clinically necessary by cesarean section. We have talked about this in previous class that it is of four categories, where first, where the placenta is reaching up to the internal os. Second, where the placenta is partially covering the internal os. Third category, where the placenta is covering the internal os but not fully when it is dilated. And fourth is when it is totally implanted over the cervix. It can be associated with heavy bleeding at cesarean section because of placental invasion of the myometrium. That is, placenta previa patients may be associated with that of placenta accreta, increta, or percreta, or the placental growth through the old scar of a previous cesarean section. And we all know that previous cesarean section is a very much risk factor for placenta previa as well as for placenta morbidly adherent placenta, which might include all the three categories. Delivery consideration is we have to avoid difficult forceps and vacuum deliveries, because we all know that forceps might result into very bad lacerations and trauma to the vaginal tract that may even result into the fornicles lacerations, and the patient might bleed to death. Vacuum deliveries are also very traumatic. Then we have to consider delaying or avoiding episiotomy before crowning, because the thickness of the perineum is too much and it might result into bleeding. And epidural anesthesia seems to help us. Attendant for newborn, so maternal care is not compromised, and blood bank availability should be there. Then uterine rupture, usually it occurs with prior cesarean section 1 to 2%. In modern obstetrics, in unscarred uterus, it is present in 1 in 10,000 to 1 in 20,000. In neglected labors, this accounts for many maternal deaths where modern obstetrical care is not available. Previously, when training of medical officers were not there for those who have joined to peripheries, the oxytocin-induced uterine ruptures were very common, but after the trainings, these have been decreased. Hello? Hello? Am I audible?
Yes, ma'am, you are audible.
Somebody wrote that screen is not visible. Is it so?
It is visible, ma'am.
It is visible. Huh? Should I continue?
Yes, ma'am.
Okay. Then early prenatal care should be given so that the identification of high-risk cases can be done, and confirm the intrauterine pregnancy and give correct gestational age by early ultrasound, because the ectopic pregnancy is also one of the causes for obstetrical hemorrhage. Then we have to identify risk factors by history, like that of previous postpartum hemorrhage, previous history of blood transfusion, any kind of coagulopathy, or there was any kind of cesarean section or surgery or scarring of the uterus was there, any history of anemia or blood transfusion history is there, any history of raised blood pressure for that patient, might be taking any blood drugs and all. So proper history taking is also very important to rule out that the patient may land up into postpartum hemorrhage or any kind of obstetrical hemorrhage. Even those patients, those who had recurrent bleeding in previous pregnancies, might land up into again into bleeding. Then potential for prevention is this: smoking has to be stopped, any kind of drug addiction like cocaine has to be looked after, and education of the patient is very important, and providing emergency communication and care. Routine management of care on admission for delivery includes decreased rate of vaginal birth after prior cesarean section, that is with close monitoring, intravenous lines for all patients admitted in labor or for induction, close monitoring of maternal and fetal condition until after delivery. So every patient that we are admitting should have IV line maintained. Then cesarean section patients, if we are going for VBAC, should be monitored very carefully so that we can rule out any scar tenderness or scar rupture in time. And close monitoring of maternal and fetal condition should be done in every delivery. Initially, laboratory workup is very important. ABO, RH grouping and cross-matching is important. Hematocrit workup is important. Every patient, so we all, it's a protocol to do hemoglobin and routine microscopy in every patient in every month of antenatal period. And second trimester ultrasound for placental position and other risk factors, like if the patient is of prior cesarean section and the placenta is anterior, we should always go for a Doppler study of the placenta to rule out any morbid adherent placenta. Even if the patient is not able to afford MRI, even Doppler study is also equally good. Then blood pressure has to be monitored on every visit so that we can rule out early development of hypertension, and treatment can be given at time. Emergency access to hospital level care should always be asked for, whether the patient is living near to the hospital or far away, and how she can approach to the hospital in case of emergency. Then polyhydramnios patient should always be told about that in case of leaking, they should immediately inform to the labor unit, so that the chances of cord prolapse are not there, and even abruptio is very common in case of polyhydramnios patients. Then for the placenta, deliver intact, and in 20 minutes, missing fragments should always be looked after for after delivery. And if manual extraction is needed, then alert the operative team of the potential need for laparotomy, because manual extraction may further is a risk factor for postpartum hemorrhage. All patients should have blood recording, typing, and antibody screening by the time they are admitted for delivery. And patient at risk for obstetrical hemorrhage should have blood drawn on admission to either hold in the blood bank or cross-matching. On recognition of hemorrhage, we have to initiate the volume replacement with ringer lactate or normal saline. We have to alert the blood bank team and the surgical team. We have to do every attempt to control the blood loss, initiate the decisive therapy, and monitor for complications. And blood loss, we all know that we can control by oxytocin, that uterine tonics like oxytocin, initially by uterine massage, then by oxytocin, then we have to give methergin. If the patient is not hypertensive, then we go for prostaglandins, like prostaglandin F2 alpha if the patient is not asthmatic, that is carboprost. Then mesoprost can also be used simultaneously to prevent the blood loss, and this is the protocol that we have to follow. Control the blood loss immediately, explore the uterus for any retained placental tissue. Uterine massage has to be given. Then uterine atony, like in presence, has to be treated with oxytocin IM or IV, methyl argonovine, 0.2 milligram IM, or prostaglandin F2 alpha 0.25 milligram IM. That could be repeated every 15 minutes up to 8 doses. Then we have to inspect the cervix, vagina, and perineum for any lacerations and apply direct pressure until sutures stop bleeding. Identification and ligation of arterial bleeding is preferred if possible. Then if hemorrhage is not controlled by medication, massaging, manual uterine exploration, or suturing, then surgical or radiological options must be considered. And at this time, we have to start for packed RBC transfusion, and Foley's catheter should be inserted and monitoring of urine output to be done. If the patient is stable and bleeding is not torrential, then if interventional radiology is available, then pelvic arteriography may show the site of blood loss, and therapeutic arterial embolization may suffice to stop the bleeding. And in case the bleeding is torrential and is bleeding occurring at cesarean section and torrential, or pelvic hematoma is expanding, or bleeding is uncontrolled by other means, then laparotomy may be required. And we have to continue to replace the blood loss with fluid and packed RBCs, add fresh frozen plasma, and